Obesity. Normal BMI is 18.5 to 24.9 kg per meter square. Overweight is 25 to 29.9. Class 1 obesity is 30 to 34.9. Class 2 obesity is 35 to 39.9. And Class 3 is more than 40. Of course, in Indians, it's less. The etiology. There are two theories. One is an energy balance model in which it says the intake more than the output in terms of calories would cause obesity. The carbohydrate insulin model. It says that if you take foods with high glycemic index, there is insulin secretion and calories are deposited in fatty tissues. And then there is the individual factors, environmental factors, and socioeconomic factors. Individual factors would be any medical condition in which the patient cannot go about and exercise, hypothyroidism, pregnancy, drugs, menopause. Then there is the socioeconomic factors in which you have food, the diet that people take, sedentary lifestyle, perinatal exposures, and then you have the microbiome of the patient, genetics, viruses, and environmental factors. You have pollutants, endocrine disruptors. So dietary factors, it's shown that ultra-processed food and calorie-dense food, which causes an increased sugar intake, increased trans fat intake, and low fiber intake, they are tasty and they produce cravings, and the patient ends up eating more and they cause obesity. High fiber diets promote satiety and increase glycemic control. In a cohort study, unprocessed foods like whole grain, fruits, and nuts was associated with weight loss in the long run. Increased fast food intake is associated with increased weight gain, and it says that for every fast food meal per week, there is 0.05 kg per meter square increase in BMI over 3 years. Increased sugar-sweetened beverage use, like example, you put sugar in your tea and coffee and milk, or even colas. They are strongly associated with type 2 diabetes and weight gain. Recommended exercise is 150 minutes per week of moderate exercise, 75 minutes per week of rigorous exercise, and 2 days per week of muscle strengthening exercises for an adult. And for children and adolescents, 60 minutes per day of exercise is necessary. And it is shown that every 2-hour increase in television watching is associated with 23% increased risk of obesity and 14% increased risk of diabetes in the child. Genetics. The greatest risk factor for childhood obesity is the first-degree relative having it. Single gene defects associated with obesity are present in 2%. And we have the MC4R gene, which is the melanocotton 4 receptor gene, leptin gene, POMC gene, and there is the heritable intestinal microbe, in which Christensenellacea group. If the child inherits that intestinal microbe, is associated with leanness. Obesity syndromes. Albright syndrome, in which there is obesity, mental retardation, and short stature. Alström syndrome, in which there is obesity, type 2 diabetes, blindness, and deafness. Lawrence-Moon-Beadle syndrome, there is obesity, retinitis pigmentosa, again associated with blindness, renal malformations, mental retardation, and hypogonadism. Carpenter syndrome, in which there is obesity, umbilical hernia, syndactyly, mental retardation, and congenital heart disease. Prader-Willi syndrome is associated with obesity with hyperphagia, hypotonia, mental retardation, small hands and feet. Perinatal factors associated with obesity. Maternal smoking is associated with 50% risk of childhood obesity. Gestational diabetes, maternal overweight. It's shown that 89% of children born to mothers who are overweight during their pregnancy have a risk of childhood obesity. Medical conditions associated with obesity are Cushing's syndrome, hypothyroidism, which is in 14% of obese people, PCOS. The drugs associated are antidepressants, antiepileptics, and antipsychotics, antihypertensives, insulin secretagogues like limepiride, OCPs and steroids, antihistamines. Smoking causes an increase in energy expenditure about 10%. Stopping smoking is what causes weight gain. That's shown to be 5 kg in women and 4.4 kg in men. The complications of obesity. The risk of carcinoma. So the cancers that are associated with obesity are stomach cancer, esophagus, colon, rectum cancer, liver, gallbladder, pancreas cancer, breast, ovary cancer, renal, thyroid carcinoma, and meningiomas. Adipose tissue produces hormones which promote tumor cell growth. Treating the obesity decreases the 10-year risk of cancer by 37%. Then there is cardiovascular disease associated with obesity, diabetes, 7.3-fold higher risk for diabetes in those that are obese versus those that are lean. Losing 10% weight reduces the risk of diabetes by 80%. Gallstones. This is seen in 10 to 25% of obese people. Obesity causes insulin resistance, and this causes increased cholesterol synthesis in the liver and also excretion into the gallbladder. Weight loss also is associated with gallstones. This is because the flux of cholesterol mobilized from the fat, and this is passed out in the biliary system. This is especially seen in the weight loss more than 25%. GERD, 40% of patients with class 3 diabetes have a hiatus hernia. Barrett's risk is also high in obesity. Class 3 obesity has a 3 times risk for esophageal carcinoma at the GE junction due to a GERD. Hypertension, 35% increased risk of hypertension in obese people. Then there is infertility, osteoarthritis, dyslipidemia, depression. The treatment of obesity, the diet. What are the types of diet we can prescribe? One is a low carbohydrate diet. Now this causes increased satiety, reduction in triglycerides, and a reduction in the blood pressure. Ketogenic diet is an extreme form of diet in which you replace most of the energy substance that you consume with fat rather than carbohydrates. So you reduce the carbohydrate, increase the fat to 70% of intake. But the side effects are halitosis, constipation, increased risk for hepatic steatosis and NASH, increased dyslipidemia, and increased cardiovascular risk. Low-fat diets. This is associated with the same amount of weight loss as a low-carbohydrate diet. But there is the added advantage of reduction in LDL cholesterol and a reduction in cardiovascular risk. High-protein diets are associated with a low appetite, and there is no muscle mass, unlike in a low-carbohydrate diet. However, in the long run, you give them high protein, they can cause kidney damage, kidney stones, and osteoporosis. Low glycemic index diet. This causes a reduction in cardiovascular risk and a reduction in HbA1c. Intermittent fasting is also shown to be good in the sense that patients adhere more to it. Meal replacement diet, in which you replace one entire meal with a liquid protein drink. Low glycemic index foods are foods that have less than 55 glycemic index. Medium would be a glycemic index of 56 to 69, and high glycemic index foods have more than 70. Pharmacotherapy, which is anti-obesity drugs. Firstly, phentermine topiramate ER combination. This is good especially if the patient says that they have migraines or seizures. You can control both. The EQUIP trial shows a loss of 10.9% weight compared to 1.6% in placebo. But the side effects are paresthesias, giddiness, dysgeusia, constipation. There is a risk of malignant hypertension if other sympathetic amines like cheese are used. Oristat. This is given at a dose of 60 mg TDS to 120 mg TDS. It inhibits GI lipases and therefore inhibits fat absorption. And this causes a weight loss of about 2.8 kg in 4 years. The side effects are the patient has fecal urgency, oily stools, and sometimes fecal incontinence, and cause a deficiency of A, D, E, and K vitamins. Naltrexone SR, bupropion SR. The combination. This modulates the reward pathway of food intake. And the core 1 and 2 trials are the ones that took this into account, and it showed a 5 to 9% weight loss. The side effects are dry mouth, headache, and insomnia. Setmelanotide. This is an injectable MC4R agonist. It's used in children with POMC deficiency or LEPR deficiency, and it can be given in children more than 6 years. That's setmelanotide. GLP-1 agonist, that is, glucagon-like peptide 1 receptor agonist. GLP-1 is an incretin that is secreted by the L cells of the ileum. And this is secreted in the presence of food. So it stimulates satiety, it promotes insulin release from the pancreas, it inhibits glucagon release, and also binds the GLP-1 receptor in the hypothalamus, activating the POMC and inhibiting neuropeptide Y. And therefore there is increased satiety and there's weight loss. All the GLP-1 agonists are approved for diabetes, but only semaglutide and liraglutide are approved for obesity. There is a black box warning that it causes medullary thyroid carcinoma in rodents. It's not proved in humans, but it's not given if there is a family history of medullary carcinoma by thyroid or MEN2A. The side effects of GLP-1 agonists is dyspepsia, vomiting and diarrhea, constipation, and gallstones. Semaglutide. There are 2 main trials for semaglutide. One is a step 1 trial in which 2.4 milligrams subcut of semaglutide was given for 68 weeks, and it showed a 14.9% weight loss compared to 2.6% in placebo. Then there is a SUSTAIN 6 trial in which it was studied in type 2 diabetes and showed a 26% decrease in major cardiovascular events. Tirzepatide, not tirzepatide, TIDE, combined GLP-1 and GIP agonist. GIP is glucose-dependent insulotropic polypeptide receptor agonist. The main trial for tirzepatide is SURMOUNT-1 trial, in which 15 milligrams subcut was given weekly, and it showed a 22.5% reduction in weight versus 2.4% in placebo. The newer ones that are still in trials, phase 2 trial, is retatrutide. This is not only GLP-1, not only GIP, but also glucagon receptor agonist. 12 milligrams is used and showed a 24.2% reduction in weight versus 2.1% in placebo. A newer one called oral orforglipron is a non-peptide GLP-1 agonist and shows a 14.7% reduction in weight versus 2.3% in placebo.